I'll be giving you a very brief account of vitiligo with reference to its pathogenesis, clinical features, and treatment modalities. Vitiligo is an acquired pigmentary disorder of the skin that is characterized by circumscribed depigmented macules and patches. The condition is frequently associated with disorders of autoimmune origin, with thyroid abnormalities being the most common. Apart from this, the most important aspect on the pathogens of vitiligo is the breakdown in the antioxidant defense mechanism of the skin as well as the body. Now, the lesions of vitiligo are characterized by white or depigmented patches and macules, usually well demarcated, round, oval or linear in shape. Borders will be convex. They range from millimeters to centimeters in size, and they enlarge centrifugally over time at an unpredictable rate. The initial lesions occur most frequently over the hands, the feet, the forearm, and the face, favoring a perioral and periocular distribution, apart from indicating a form of sun sensitivity. There are several clinical variants. To mention a few: trichrome vitiligo, quadrichrome vitiligo, marginal inflammatory vitiligo, and vitiligo resulting from pulverization, that is, over areas of trauma such as cuts, burns, abrasion. Although the diagnosis of vitiligo generally is made on the basis of clinical findings, biopsy is occasionally needed to differentiate vitiligo from other hypopigmented and depigmented patches of the skin. Microscopic examination of involved skin shows a complete absence of melanocytes in association with total loss of epidermal pigmentation. There is superficial perivascular and perifollicular lymphocytic infiltrates at the margin of the vitiligenous lesions, consistent with a cell-mediated process destroying the melanocytes. Other documented histopathologic findings include degenerative changes in the keratinocytes and melanocytes in the borders of the lesions and as well as in the adjacent normal skin, increased number of Langerhans cells, epidermal vacuolization, and thickening of the basement membrane. The loss of pigment and the loss of melanocytes in the epidermis can be highlighted by the Fontana-Mason staining and immunohistochemistry testing. The management can be classified broadly into two forms: non-surgical and surgical. Under non-surgical treatment comes the most popular phototherapy, which induces satisfactory repigmentation in the majority of patients with early and localized disease. Topical corticosteroids as well as topical calcineurin inhibitors are found to be useful. They can be used either separately or in combination. Now, with regard to laser therapy, it's found to be effective on limited stable patches of vitiligo. Depigmentation therapy is one thing that can be tried in extensive lesions which do not repigment after repeated attempts. Now, this can produce satisfactory results by depigmenting whatever areas of normal skin that are seen. Micropigmentation or tattooing can be used to repigment depigmented skin in the skin of color. With regard to surgical management, there are a few basic types of repigmentation surgery that will include non-cultured epidermal suspensions, thin dermoepidermal grafts, suction epidermal grafting, punch mini grafting, and also cultured epidermis and melanocytes or cultured melanocyte suspensions. That's it for now. Thank you very much, my dear friends.